Hi, good evening everybody. So tonight's session is about syndesmosis ankle sprains or high ankle sprains. And I'm going to look at the anatomy of the syndesmosis joint because it's not one that we talk about quite often. Why it's important to look for this type of ankle sprain, how you make the diagnosis, the grading system for different grade 1 to 4, and then we're also going to have a look at the treatment according to the different grades. So for those of you who don't know me, my name is Maryke. I'm the physiotherapist from Sports Injury Physiotherapy, sportsinjuryphysio.com, where you can get online physiotherapy assessment as well as treatment for your injuries. So have a look. There's a link to my website in the description of this video. Okay, so if you're new to the live streams, how it works is you can ask your questions as we go along. Facebook's been not actually showing the comments to me as we go along, so I will keep an eye on it. But if you feel I'm ignoring you, I'm not really. I'm just not seeing it. I will come back to them after I've done the live stream if I don't see them while I'm busy. Okay. So if you're watching this on replay, feel free to message me or email me or even just comment and make sure you tag me so that I know that the comment is there. Good. So let's jump right in. Let me just get everything. Sorry, I've played with a cat and I'm slightly allergic to cats, so now my nose is running. Okay, so if we look at the anatomy of the syndesmosis joint, I think what I'm going to do before I ramble off all these ligaments, I'm also going to show you the pictures here. Okay, so those two pictures, the top one is showing your ankle joint slightly from the outside. So it's kind of looking at it like that. So you're seeing your lateral ankle ligaments there. And then you'll notice there's one that ties the tibia and the fibula together at the bottom. And then there's a yellow bit between the two bones. So the syndesmosis joint is formed by the tibia and the fibula, the two bones coming together. They form a mortise for the talus to sit in, the foot joint basically to do that in. And the syndesmosis joint refers to all the ligaments that holds that bit together and gives it stability in there. So we've got that little ligament over the front that ties the tibia and the fibula together. That's the inferior anterior tibiofibular ligament. Then you've got that membrane between the two bones. Now the very low part of it is called the interosseous ligament, but the bit that follows up between the bones are called the interosseous membrane. Very important part for stability because it keeps it together. Then also at the back of the joint where you can't see it, but at the back of the bones, just like you've got that little ligament over the front that ties it together, you've got the same thing at the back called the inferior posterior tibiofibular ligament. And then the last part is made up of the deltoid ligament, which is on the inside of the ankle joint and spreads out, and it's the anterior part, the superficial as well as the deep part of it, that helps to stabilize this joint. So when we think of the anatomy of this joint, it's all the ligaments that keeps the tibia and the fibula together and gives it stability around that. Yeah, so we can look at the whole list of them, but I've pretty much run through them. I'm not going to run through them again. I think you've got them there. Now, why is this important? Well, first of all, because this type of injury, because those ligaments stabilizes the two bones together and your main weight goes through those bones, if you've got an instability there and you don't rehab it properly, or if it's a grade 4, you may need surgery, it can lead to a chronically unstable joint. So that's why it's important to identify this type of sprain when you look at them. Secondly, it can also mean that you've got a bit of a prolonged recovery, that it may take longer for you to get back to your sport. And especially when we're looking at elite sport, that's quite important to acknowledge. Good. So then, if we move on, are we looking at the diagnosis? Now, the first instance that should make you think that you need to suspect this type of sprain is the mechanism of injury. And the mechanism of this type of injury is severe dorsiflexion, so bending up of the ankle, and then a twist to the outside of the foot. And if I can show you a typical picture, there you can see. So the person who is going to kick the ball, if you look at his right leg, he's planted his foot and his body is twisting in on that. So what you're getting is the bone from the top has a twisting action on the foot out, and that will strain the syndesmosis joint. Now, it doesn't have to cause a sprain, but that is the mechanism that can cause a sprain. And interestingly enough, I've taken this picture from Morgan et al. 2015. I'll actually, before I forget, let me just put a link to their article in the comments, because it's a really good article. Oh, here we go. I'm seeing loads of comments coming through now that I've commented. Hi Tony, I can see you've said hi. I can't see any of the other ones, which I can just vaguely see there, but anyways, that's okay. Okay, so that article, I'm going to talk under correction now. I think it was either 4 or 5 injuries that they had of this type in a season, and they were all caused by contact, so tackles. And if you think of it, it's a very common thing for somebody to step on somebody's foot in football or go in for a high velocity tackle. So it's quite, they used to think it's not that common an injury, but it seems to be more common these days, and they don't know if it's just that it's being reported more often. So if you can look back at the footage of how the injury happened, amazing, because then you really see the mechanism of injury. But if the person tells you that the foot got bent up and then twisted, then you have to suspect this type of injury. It's not that common that you can get a high ankle sprain with a normal way the ankle just twists inwards. It's when that foot twists outwards and you get that bend in the ankle, the dorsiflexion. Then you've got a set of clinical tests you can do to test for this. And the one is exactly the injuring movement. So you will take the patient's foot and his knee is in 90 degrees flexion. So let me see if I can demonstrate this for you. So you will take the person's is sitting comfortably with his knee bent over a chair or table where it can hang free. And then you'll literally take the foot into dorsiflexion and turn it out so that you strain the syndesmosis joint. And what the research is showing, that test is really specific, that if that causes pain, then you do likely have a syndesmosis injury. It can't tell you how severe it is, but it's a good sign that there is one present. Then the second test, which actually has good predictive value for predicting how long it will take for you to recover and return to full sport, is the squeeze test. And what you do with the squeeze test is you literally, so if you think of it, that there's this membrane running between the two bones, connecting them together. So with a squeeze test, you squeeze the two bones, the tibia and the fibula, together, and you look for pain response lower down, because by squeezing it, especially at the mid-calf level, you're gapping the bit at the bottom, and if that's injured, that will cause pain. What the research is showing is that if that does cause pain, it's a sign that your injury will likely take a bit longer before you can go back to full sport. Then you can also just palpate along that line where the membrane runs. If that's painful, you've likely got a syndesmosis injury, or over the anterior inferior tibiofibular ligament, the little one at the front. All of those can be a sign that you've injured it. X-rays aren't that useful, especially if they're not loaded X-rays. So if they're taking an X-ray of somebody with a leg just sitting down, there's no weight going through, it may not show a gapping in the bones or anything. And even if they have up to a grade 3 or so injury, even if they're standing on that leg, it may still not show a gapping. So X-rays are really not that useful to show this type of injury. What they are useful for is to show fractures and things, because often the forces that goes with this type of injury to create this injury is really high, and it can cause fractures of your osteochondral surfaces, so inside the joint, the articular surfaces. It can cause fractures of the lateral malleoli, the medial malleoli. So X-rays can be a good one to rule out fractures if you've got bony tenderness. But then again, they're not really that sensitive either for intra-articular fractures. That's why MRIs and CT scans are really better for that. MRI scan seems to be the gold standard for investigating syndesmosis injuries, because you can see if ligaments have edema in it, so just swelling in it for grade 1, or whether there's actual ruptures. And if you're lucky enough to work in high-end sport, MRIs are great because you can immediately request them normally. But now what to do if you don't have access to MRI scans? You know what? Don't stress about it. Mechanism of injury is high suspicion of that type of injury, and then your clinical tests, which is the squeeze test and the lateral rotation test and palpation, can give you a good indication if this has been injured. And then you can just treat your patient according to their symptoms. And I'll talk about the treatment a little bit later. So don't worry if you can't get an MRI in the first instance. It is best if you can, but you can treat people without having that in the first instance. CT scans can be really useful if you suspect that there are fractures that may not have been picked up on MRI scan or on X-ray, because sometimes if there's a lot of dulled signal because of other injuries in the soft tissue, you can't see the fractures on MRI scan that well either. But it's all about looking at the whole picture in front of you. They reckon that doing the clinical tests on the day of injury, so the lateral rotation, the squeeze test, is not that sensitive because everything's painful at that time. It's better to give it about 5 days so that things can calm down, and then you're going to get a more accurate idea about which ligaments and things have been injured. So if you've got a player on the day of injury that you suspect they may have that, assume they've got it until you've ruled it out, but give it 5 days of rice regime and things to calm it down before you do your exam again. What was the other thing with this now? Clinical tests. I think that's all I wanted to say under diagnosis for now. So if we move on and we look at the grading system. There are several different ways that they grade how bad your high ankle sprain is. Now the grading system I've used here is one that they use for MRI scans. So when they look at the scan, they look at which ligaments are injured, to what extent, and then they grade it from 1 to 4. So for grade 1, only that little ligament over the front which ties the tibia and fibula together, the anterior inferior tibiofibular ligament, only that one's injured. Grade 2, you've got that one as well as your interosseous membrane, so that bit that runs between the two bones, that's injured. Grade 3, you now have the posterior inferior tibiofibular ligament as well, so the little one at the bottom that ties the two at the back. Interesting to note that 42% of the strength of this joint is dependent on that little ligament at the back. So when you get to a grade 3 where that ligament is injured and it's a significant tear in that one, then it becomes a more significant injury. So remember also, it doesn't matter, it's not about, oh, this ligament is injured, so it's definitely bad. It's about the extent of the injury to that ligament as well. And then grade 4 is where you've injured all of those, but also the deltoid ligament, so the one that runs around the inside there. And usually with grade 4s, you need a surgical opinion because they tend to be unstable sprains then. What they seem to suggest in the research as well is a good indication that it's likely only a grade 1 tear is if a player injures himself, but he can get up and he can continue the match and only complains about pain afterwards. Usually if it's a grade 2 or 3, they have to come off the pitch. Okay, so if they can continue playing, likely they've got a grade 1 tear. And I would actually suggest the link that I've put in the comments. That article is really good because they describe how they've treated I think it's 4 different cases that they had in the season. And what's useful there to see is how they did it according to the severity of the injury. So there's a rough guideline of what you follow, but it depends on how bad the injury is, how much you protect it versus how much you push it. For grade 1 tears, the professionals only lost about a week out of full training and they didn't lose any matches. Whereas grade 3, they lost 10 weeks worth of active play. And I would say that actually, if you're not in an elite football team where you're getting that specific input every day, you will likely take more than 10 weeks because you won't have that specific guidance and the access to all the fancy equipment that you may benefit from if you're in elite sport. Which moves me on to treatment. So I've touched on this. Grade 1 to 3, you can usually manage conservatively. The more severe grade 3s, you may need a surgical opinion for, but it's always best to really try conservative management first. And if you find that that doesn't work, definitely refer them on for further investigation and a surgical opinion. Grade 4s usually need a surgical opinion to help stabilize that joint again. Now, if we look at the treatment regime is very similar to many other ankle joints, but I've highlighted in red there, avoid dorsiflexion. So for other ankle joints where you've got quite stiff joints and things, people will go in and they'll really mobilize that dorsiflexion range of movement. Dorsiflexion means how much the foot bends up. Now, when we're looking at syndesmosis injuries, if you're going to force that dorsiflexion range of motion, it naturally tries to gap the two bones apart. So if you've got a ligament that's trying to fix itself and trying to grow together, and you force that dorsiflexion, you're just gapping it, so you're disrupting the fibers. So you may end up actually causing instability in your joint because you're not giving it that time to heal. Now, it doesn't mean avoid dorsiflexion forever and ever. It will depend on your grade of injury, how long you avoid it for. So for instance, with the grade 1 in that study I've spoken about, link is in the comments, they only avoided it for a few days before they started reintroducing it. Whereas with the grade 3s and 4s, they avoided it for 4 weeks solid, and then they had a slow reintroduction of it so that it didn't go bang into full-on stretching. They went into various degrees of it so that they could test what the ligaments were happy with. So in the first instance, doesn't matter which injury you've got, you want to offload that injury and apply RICE regime. So rest, ice, compression, elevation, anything you can do within the first 3 to 5 days to just help with swelling and help with the inflammatory phase and get it to calm down. Spoken about dorsiflexion, then again, depending on the severity of the injury, you usually want to go through a partially weight-bearing stage. And if you think about it again, it makes sense because, so with lateral ankle sprains, when you walk on a straight line and you just stand on your foot, you're not actually putting pressure on those ligaments because they're to the side of the foot. Whereas with these ligaments, because they're holding the bones together, if you're going to stand or just stand still on it, your weight going through it onto the foot wants to splay those bones apart. So that's why you need a period of partial weight bearing where you slowly go according to how strong the ligaments are. How do you know how strong they are? Pain response. See how the patient reacts. If you've got the luxury of MRI scans, you may actually be able to progress them faster or more quickly because you can see the extent of the injury. If not, I would say add a week or 2 in, be a little bit more conservative, and get them to work in the swimming pool. That's a very good way to be partially weight bearing with walking, with doing heel raises, with doing balance exercises. If you've got access to anti-gravity treadmill, amazing, but not all of us do. So swimming pool is a great way to take some of your weight off. Using crutches for when you walk around, things like that. Then calf strength is very important, but again, think of your stage of healing. So if you're in a non-weight bearing or a partial weight bearing stage, you can't go and do heel raises on a single leg to strengthen it. You have to do things like TheraBand exercise or just isometric presses, stuff like that. So you've got to think about your healing process and where you are in that. Again, in that study, they found that inverter muscle strength, so that's your tip, post, tip, ant, that seemed to lag a bit after this type of injury. So they worked on strengthening that as well. And it makes sense because that helps to stabilize the ankle. So it's anything where you turn the foot in. Those are the muscles, the inverters. So loads of TheraBand work with pulling the foot in against resistance. Taping technique. Now please tell me I've got the taping technique on here. I have a feeling I didn't put it on here. Oh, they've got a really good taping technique. You're going to have to go look at that, that article for that. Sorry about that. I thought I'd put it in here. Let me just see if my capabilities is that I can actually add it while we speak. Let's see. So the idea with the taping is that you help to supply some extra support for those ligaments. Now, a regular ankle brace won't really do the job, because a regular ankle brace only, there we go, only stabilizes the ankle in that direction. What we need is we need something to keep those bones together and really stabilize the inside of the ankle. So what you'll notice there is they are doing strips around the bottom of the foot, or the lower tib fib, to keep them together, so that helps the membrane. And then they've applied a heel, what do you call it now? Anyways, a wrap around the heel lock, that's the word I'm looking for, which supports the inside ligament, the deltoid ligament. And they've applied quite a lot of tape to that. But by doing that, they could get their players back to doing active things on the pitch without re-injuring it. So that may be really worth looking into if you want to get your players back quickly. Okay, so how do I get that out of the way? Good, so that's for taping. Then balance and proprioception, always extremely important. So remember, proprioception is the fact that when you close your eyes, your brain knows exactly where all your body parts are, your tips of your fingers, your ankles, everything. Your position sense is determined via little receptors in your ligaments, your tendons, your muscles, all of that. And when you've injured ligaments, that message from that injured body part gets a little bit muddled to the brain. Now, you can imagine how many calculations goes through your brain per second for it to calculate how it needs to place your foot when you're running, which muscles to contract, all of that. So it's really important that your brain knows exactly where your ankle and your foot is as you're walking and moving. Very easy to retrain. It's through various balancing activities. But what I would say is, remember again, if you're non-weight bearing and you can't put your full weight through it, do it in the swimming pool. It's a very good place to be standing on one leg, and you can use your arm resistance through the water and things to try and throw you off balance. So there's loads of ways that you can work on it if you can't yet weight bear fully. Then after that, you want to work on balance on the flat ground. Make sure that you can properly balance on flat surfaces before you actually think of wobble boards and things. These days we know that wobble boards aren't that useful. We tend to use loads where you're on one leg balancing and then pulling with arms and stuff, that you try and get loads against you that makes you unstable, rather than standing on an unstable surface. Because let's face it, when you're running, the floor's not unstable. So unless you're a surfer or somebody who works on boats, being on a wobble board is not really that appropriate. But it has its merits at the beginning, especially to teach you just how to move your ankle in certain directions. But don't get fixated on that, is basically what I'm trying to say. Then once you can get back to running, then you usually train running in straight lines first, so that you have quite directional or straight line force through the joint. And then from there, you'll progress the athlete to doing more directional changes and things. But at that point, that ankle has to be pretty strong and really symptom free. And again, it can help if you have some tape around it at the beginning when you go back to that. And also plyometrics is a very good thing to add into that. So I guess the take home message with this is, think about the mechanism of injury when somebody says they've sprained their ankle joint. If there's any indication that it could have been a dorsiflexion, external rotation of the foot, in any case, I would always test the squeeze test. I will always palpate those ligaments, and I will always just do the lateral rotation test, because you may miss it if you just only do it when you suspect it. Then, if you think it is a syndesmosis injury, remember they can be unstable and they can cause chronic instability. So you have to really manage them well. Do not force dorsiflexion at the beginning. Be conservative with it. In fact, I find often, instead of forcing people to really stretch into dorsiflexion, I find doing double leg heel raises over a step much more useful, that they get it through movement rather than trying to get it through sustained stretching. Excellent. Let me know if you've got any questions. And remember, if you need more help with injury, you're welcome to consult me via video call. Link is in the comments. Take care.